So one major evolving area of discussion in non-small cell lung cancer is the use of maintenance therapy. So I think first we should begin by discussing whether it should be used and why it should be used and with which drugs. Two potential scenarios: the patient is started on a standard ECOG 4599 regimen, PAC carbo bev. Are there any data to support continuing bev? Should there be switch maintenance in that setting? And then equally popular regimen, perhaps even more popular regimen in the US these days, PEM carbo. What are the data there? And we'll start off with Mark, if you can just briefly highlight some of the pertinent studies, the original JMEN and then Paramount trial, and then the AVAPERL and Point Break trials.
Right. So the field has gone from initially ECOG 4599, where we didn't call it maintenance, we called it treatment till progression. And that was the paradigm that was established. But we don't have a true BEV maintenance trial that has answered that.
We've never isolated it.
We've never isolated the event. But that's what most of us do when we use BEV in the first-line setting. And then after we kind of established that second-line therapies are effective, we took the 3 second-line approved drugs and used them earlier, and we called it maintenance. And we limited it to patients who had 4 cycles with either responding or stable disease. And we also there showed a survival benefit in initially JMEN in the Saturn trial, leading to FDA approvals for maintenance strategies for pemetrexed and erlotinib. And then obviously all of those maintenance trials were done in without the presence of bevacizumab. I'll leave the Atlas trial alone for a second. But then the question came: if in a Bev eligible population, what's the appropriate adjuvant maintenance approach? Atlas, although a positive trial because the primary endpoint was PFS, did not show an overall survival advantage.
Unlike Saturn.
And so the next wave became the use of pemetrexed. Pemetrexed had initially studied as a switch maintenance drug, then based upon Paramount, studied as a continuation maintenance trial, again a positive trial for the effect of continuation maintenance, both in PFS and overall survival. And then we had the next generation of bevacizumab-related trials, both Point Break and AVAPERL, that really asked the question of Bev plus or minus a PEM maintenance therapy and those sorts of things. The trials are of different design. Point Break randomized patients before the initial 4 cycles, and then patients continued on the carbotax Bev with Bev alone, carbo-PEM Bev with Bev plus PEM maintenance sort of thing.
So really 2 separate variables.
2 variables. That trial was a completely negative trial. The endpoint was overall survival. It did not show a difference. It did not show a difference in overall response rates. In my opinion, it showed a modest, statistically significant benefit. I'm not overwhelmed by the clinical significance of the PFS benefit that was seen. AVAPERL, a different design. Patients got 4 cycles of cisplatin, PEM, Bev, and then those patients that didn't progress and made it through 4 cycles were then randomized to Bev versus Bev plus pemetrexed. It actually showed a more striking difference in PFS than Point Break showed. But yet, even though we don't have the final word on overall survival in this.
But it's not positive.
It's not positive, right.
One could also argue it was an underpowered trial.
Right. So, again, that's kind of brings us up in, I'm sure we'll talk about the ECOG trial, which is the next logical extension in this question of what's the appropriate maintenance strategy in this population.
So, Heather, if you can mention the ongoing ECOG effort?
Sure, and the PI for that is Suresh Ramalingan. And what that study is really trying to do is answer some of those maintenance questions. So the study, the backbone is the carboplatin, paclitaxel, bevacizumab, ECOG 4599 regimen. And patients who have been on for the 4 cycles without progressing are at that time randomized to either stay on bevacizumab alone, a la ECOG 4599,
the standard arm,
to stop bevacizumab, and switch to pemetrexed maintenance.
So a variation on the J-min approach.
A variation on the J-min, and really for the first time a randomized trial of bevacizumab or not as maintenance. Now it's not bevacizumab or nothing.
Observation,
It's bevacizumab versus a single chemo without the bevacizumab. So it's not going to fully answer the question, but there were a lot of concerns that we would never be able to enroll to a trial where there was a halt. Where the bevacizumab was stopped and nothing else was started. And so that's why it's only a 3-arm trial.
So the third arm is the
third
combo.
arm is the combination. So you've got continuation bevacizumab, 4599 control, stop bevacizumab, go to pemetrexed, or go on both. And so that trial's accruing quite well. And it's going to be a little while before we have the data out, but hopefully we'll be able to finish enrollment in 2014.
Be one of the biggest
yeah.
maintenance trials. I think it's slated to have nearly 1,300 patients.
Yeah, we
total.
had just increased a little bit, so it's very exciting.
So.